Good morning, viewers. And in this lecture, I'll be discussing regarding the management of malignant mediastinal mass, more often seen in the oncology OPD, and then how to deal with it, and then how the radiation oncologists are utilize its best of capabilities here in the management of mediastinal mass, particularly malignant mediastinal mass. Basically, mediastinal mass causes a superior vena cava syndrome is because of obstruction of superior vena cava in the mediastinum that leads to the superior vena cava syndrome. The mediastinal mass may be benign or malignant both. It can develop by from the structure that are located in mediastinum, the primary mediastinum, as well as the lymph node present in the mediastinum. They cause the superior vena cava syndrome, enlargement of lymph node, as well as the various site of body like a testicular tumor that goes in the mediastinum that lead to the mass lesion in the mediastinum, and various malignancies from the other side to reach to the mediastinal lymph nodes, and then that causes the superior vena cava syndrome when the lymph node is large enough and compressing the superior vena cava. The approach to a patient with a mediastinal mass shall be reviewed here in this presentation, as well as the approach of a radiation oncologist, clinical oncologist, and then the investigation, basically the special investigation required for the treatment will be described. In addition, the brief summary of a most common cause of a mediastinal mass coming in the oncology outpatient department shall be described. The superior vena cava syndrome is basically superior vena cava is formed by the right and left brachiocephalic vein. It courses along the right middle mediastinum with a trachea and ascending aorta on its left and drains finally into the right atrium of the heart. The compression of superior vena cava lead to multiple signs and symptoms in the patient. Among all the signs and symptoms, the breathlessness is the topmost symptoms, the most common, and sometimes it becomes life-threatening because of a large mediastinal lymph node causing the superior vena cava syndrome. The causes of superior vena cava syndrome can be categorized in the malignant causes and the benign causes. Among the malignant causes, the lung cancer is the most common cause, particularly those who arise from the proximal bronchial lesion, more commonly like a small cell carcinoma. And the second cause of malignant is most common in the lymphoma. There's a large mediastinal lymph node of a lymphoma causing the malignant cause of superior vena cava syndrome. The neuroblastoma, mediastinal mass, non-seminomatous germ cell tumor, and then as well as further characteristic 5, the extragonadal non-seminomatous germ cell tumor or rises in the causes a breathlessness. Like one of the famous cricketers developed the extranodal non-seminomatous germ cell tumor, extragonadal non-seminomatous germ cell tumor. He had a diagnosis. No, he is fine. Then thymoma, mediastinal lymphadenopathy. These are the malignant causes of this thing. The benign causes, so far as concerned, the catheter-induced superior vena cava obstruction or stenosis is being the commonest benign cause of developing the superior vena cava. The other cause is the retrosternal goiter, the histoplasmosis, coccidiomycosis, blastomycosis. This fungal infection causes the superior vena cava syndrome, aortic aneurysm. And among the lung carcinoma, the small cell carcinoma is the commonest cause, almost 60 to 70% cause of malignant superior vena cava syndrome, which is preceded by the lymphoma, rated second cause of superior vena cava syndrome. So what is the pathophysiology of superior vena cava syndrome? The enlarged lymph node or as well as the primary tumor in a mediastinum may cause the comparison of a compression of the superior vena cava that leads to the superior vena cava syndrome. Sometimes the thrombosis within the lumen of superior vena cava syndrome, superior vena cava, that leads to the problem of superior vena cava syndrome. But I repeat this: the thrombosis within the lumen of superior vena cava is difficult to manage, and how it will be managed will be seen, because it fails the primary role of radiotherapy here. The superior vena cava syndrome basically categorized in the 4 groups. When the partial obstruction, almost 90 to 100% obstruction, with the obstruction is there, but patency of agigus vein blood flow is maintained. And the second is almost 90% obstruction, means near complete obstruction of superior vena cava syndrome, superior vena cava, with a patency of antegrade flow of agigus vein, means the flow is maintained, but the near complete obstruction is there, and patency is maintained. But in the third, the complete obstruction of superior vena cava, which lead to the reversal of blood flow in the agigus vein, which causes finally the symptoms of superior vena cava syndrome. And the fourth is the complete obstruction of superior vena cava, as well as agigus vein complete obstruction and development of chest wall collateral, which is clinically evident. So most of the cases of the superior vena cava syndrome, which will show the neck engorgement and the chest wall collaterals seen by the naked eye, you consider is type 4 or grade 4 superior vena cava, that is a final stage. So you can see here in the image, the A less than 90% or approximately 90% obstruction, and then you see the right and left brachiocephalic vein and the agigus vein. The patency of agigus vein is maintained. In the figure B, you see the near complete obstruction, 90 to 100% obstruction. Still the patency of agigus vein is maintained, though it is dilated, but the antegrade flow is maintained. But in the C, because of a complete obstruction of superior vena cava, lead to the reversal of blood flow in agigus vein. So you can see here in the C figure, the reversal of agigus blood flow in the agigus vein, that leads to the further lead to the advanced stage, in the stage 4, that is stage, you categorize the type 4, where the complete obstruction of agigus vein further leading to the chest wall collaterals, the dilated agigus vein, and this is a stage which requires urgent radiotherapy to give a relief to the patient. The clinical feature of a superior vena cava syndrome is a complaints of dyspnea, breathlessness, which I have told you, the facial puffiness, hemoptosis, dilated veins over the chest wall seen as a veins engorgement, and a further rise in the vein pressure lead to increased intracranial pressure. That's with the signs and symptoms of a raised ICT. So investigation as per the routine hematological investigation, I'm talking about the special investigation. You get a chest X-ray done, and the chest X-ray, which way you see for a mediastinum, you go for a lateral way, not a chest X-ray PA view, rather lateral view of a chest X-ray will show you the mediastinal widening and a parenchymal mass opacity lesion. When no further you can understand about the diameter of the mediastinum, and then the very specific visualization of a mediastinal lymph node and a primary lesion. You required a CT thorax to be done, which confirm that it is a primary mediastinal mass lesion or a mediastinal large lymph node, as well as the CT scan will tell you about the is there in a superior vena cava, is thrombosis present inside the superior vena cava or not, because that will decide the radiotherapy outcome of a treatment. Treatment in the light of clinical oncology or radiation oncology, the radiotherapy found to be very effective in a malignant cause of superior vena cava syndrome, but limitation of radiotherapy when there is a thrombosis of superior vena cava syndrome, because there is a mass and the veins is obstruction. So if you give a radiotherapy to that mass, lesion may melt. But certainly what happened to the thrombosis present to the superior vena cava? That will not, so that the symptoms will still maintain, and that the radiotherapy role will decrease. And radiotherapy decreases the mass, but due to thrombosis of superior vena cava, reduce the advantage of radiotherapy. So what you should do is that, like we usually give 20 gray 5 fraction radiotherapy as a palliative intent, and then to old traditional 2D planning, here the upper limit of T4 to vertebra T9, we give a 12 into 12 field size, but ideally one should get a wire mark of a patient and get it confirmed on the CT simulator, the lateral extension and the posterior extension, so that we can design the beam accordingly, so the unnecessary radiation to the heart can be avoided and the lung and the heart can be avoided. So you see here the radiotherapy planning with the CT simulator. You see here the mediastinal mass, and then a large mass compression is there, and it is so much compresses, the carina is widened enough, and then so you get in a CT simulator this CT scan done, and then you can see the depth of basically the tumor volume. You can this thing, then you can plan the beam accordingly by the contouring or the each section of the CT which is having a tumor mass, and then you can this thing. But for the palliative intent, people usually give 20 gray 5 fraction radiotherapy, this thing. But that's 20 gray 5 fraction does not sometimes work out. Why not work out? Because the superior vena cava is basically thrombosed. For that to get a good result, you require a prophylactic heparization. So the heparin injection is given with a 5,000 unit 6-hourly subcutaneous for 2 weeks for better outcome, in order to dissolve the thrombus, and then the heparin will dissolve the thrombus inside the lumen of the superior vena cava, and well as the radiotherapy will melt the outer mass lesion outside of the superior vena cava mass lesion. The people also prescribe the 1 gram per meter square cyclophosphamide immediately as an emergency purpose, but the outcome we feel that is not good as compared to as radiotherapy. So in case if thrombosis of superior vena cava present, then a stenting can be done. The percutaneous implantation of cell expanding stent into the stenosis or occluded area can provide the dramatic response in the patients. So thank you very much. This was the information I wanted to share with you, those who are working in the clinical oncology and OPD, so that the role of heparin along with the mediastinal mass lesion palliative RT enhance the result. That is the punchline which I wanted to convey to you all. Thank you very much.